Okay, guys, chapter 34, Introduction to the Endocrine System. Important terms you need to know. Anterior pituitary. This is the lobe of the pituitary gland that produces stimulating hormones as well as growth hormone, prolactin, and melanocyte stimulating hormone. Glands. Glands are organized groups of specialized cells that secrete hormones or chemical messengers directly into the bloodstream to communicate within the body. Next, hormones. Hormones are chemical messengers working within the endocrine system to communicate within the body. Next, hypothalamus. This is known as the master gland of the neuroendocrine system. It regulates both the nervous and endocrine responses to internal and external stimuli. Next is the negative feedback system. This control system in which increasing levels of a hormone, look at this, guys, leads to decreased levels of releasing and stimulating hormones. So for example, if you're taking a medication such as prednisone, you're taking it long-term, right? Your adrenal gland, which is responsible for shooting out that steroid, will make less of it because you're getting it. Okay, that's an example. So it's a control system in which increasing levels of a hormone lead to decreased levels of releasing that hormone. It leads to decreased hormone levels, which stimulates the release of releasing and stimulating hormones. It's like a cycle. So what happens is you're getting something exogenously from an outside source, which causes your endogenous source, your natural source, to make less, right? So you start making less, and then your body realizes, whoa, I don't have enough. And then what happens? It starts making more. So it's a cycle, okay? Pituitary gland. This is a gland found in the cella turcica of the brain. It produces hormones, endorphins, and I'm not going to try and pronounce this. Yes, I am. And enkephalins, and stores two hypothalamic hormones. That's the most important thing that you guys need to know about the pituitary gland, where it's located, which is the cella turcica, and that it stores the two hypothalamic hormones. Last, posterior pituitary. Lobe of the pituitary that receives ADH, that's your antidiuretic hormone, and oxytocin. Let's jump to the next page, page 570. Make sure you guys know the table, table 34.1. Endocrine glands with associated hormones and clinical effects. And you have to know all of them, guys. So the adrenal cortex, you need to know that's responsible for cortisol and aldosterone. The principal effects, increasing glucose levels, suppressing inflammation. The intestine is responsible for secretin and cholecystokinin. The principal effects, it stimulates bile and pancreatic juice secretion. Kidneys, responsible for erythropoietin and renin. What does it do? Increases RBC production and causes an increase in blood pressure. Ovaries are responsible for estrogen and progesterone. They promote secondary sex characteristics, prepares the female body for pregnancy. Pancreas, responsible for insulin. Glucagon, which is that stored form of sugar. Somatostatin, it regulates glucose and fat metabolism. Specifically, guys, in the islets of Langerhans. Parathyroid hormones, those parathyroid glands, they sit right behind the thyroid gland. The parathyroid gland is responsible for parathyroid hormone, and they increase serum calcium levels. Serum, that means calcium in the blood, not the bones. As students, you guys seem to get this confused, and they will screw you up on an exam if you don't understand this. It increases the blood calcium level, not the bone. The pineal gland, the hormone produced there is melatonin, It affects secretion of the hypothalamic hormones, especially the gonadotropin releasing hormone. The placenta, it produces estrogen and progesterones. It maintains fetal growth and development. The stomach produces gastrin, and that's important for acid production. The testes produces testosterone. That's important for the secondary male sex characteristics. And lastly, the thyroid. That produces thyroid hormone and calcitonin. And that's important for increasing the basal metabolic rate. Remember when I was running around the classroom and I was showing how everything's up, 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 up? That's the thyroid, okay? Increases the basal metabolic rate and it decreases serum calcium level. Do not confuse the thyroid with the parathyroid, because I will ask you questions on the two to make sure that you understand the difference, because NCLEX does that. All right, next page. Let's talk about the hypothalamus. The hypothalamus, this is the coordinating center of the nervous and endocrine responses to internal and external stimuli. Again, the hypothalamus is known as the master gland of the neuroendocrine system. It's responsible for regulating a number of body functions, including the body temperature, thirst, hunger, water retention, blood pressure, respiration, reproduction, and emotional reactions. It's situated at the base of the forebrain. The hypothalamus receives input from virtually all other areas of the brain. It's able to influence and be influenced by emotions and thoughts. The hypothalamus also produces and secretes a number of releasing hormones or factors that stimulate the pituitary gland, which in turn stimulates or inhibits, so it can actually produce or stop various endocrine glands throughout the body. These releasing hormones include, and you guys are going to see this a couple more times, this is going to be on your test, it's very important for you to know. These releasing hormones include growth hormone, that's your GH releasing hormone, thyrotropin releasing hormone, that's your TRH, your gonadotropin releasing hormone, your corticotropin releasing hormone, and prolactin releasing hormone. Take a look at this figure on page 572. Make sure you know all of them, and I'll give you a hint. Guess what, guys? The only two that are in the posterior pituitary is your oxytocin and your ADH. Everything else is in the anterior pituitary.
What is that saying?
Upper right, right here.
Yeah, that's the one.
I wrote posterior, ADH and oxytocin. That's in the posterior pituitary, and all of the others are in the anterior. Your growth hormone, which stimulates, obviously, guys, bone growth, your prolactin, breast milk, your TSH, for the thyroid, your ACTH, your adrenal glands, by the way, guys, sit right on top of your kidneys, okay? All of those are in the anterior pituitary, just your antidiuretic hormone, which makes you hold on to your fluid, and your oxytocin, which causes muscle contraction of the uterus. Those are found in the posterior pituitary. Make sure you guys know this. All right, that was your chapter 34. We're moving on to chapter 35. Hypothalamic and pituitary agents. Let's go over the key terms that you need to know first. Acromegaly. This is thickening of bony surfaces in response to excess growth hormone, because remember, I just told you that GH growth hormone is for the bone growth. So if the patient has way too much of it, it can cause acromegaly. Diabetes insipidus. Not to be confused with diabetes mellitus. Don't do it, guys. Diabetes insipidus and diabetes mellitus are two different things. When you think of diabetes mellitus, I want you to think of diabetes, blood sugar. Okay, that's what I want you to think of. But when you think of diabetes insipidus, I want you to think of Oprah Winfrey. You know how Oprah Winfrey loves giving away things? That's diabetes insipidus, except it's urine. You get urine, you get urine, you get urine. Everybody gets urine. Everyone is urinating all over the place to the point of dehydration. Okay, that is diabetes insipidus. Take a look. It's a condition resulting from lack of antidiuretic hormone. Well, let's think about this. Antidiuretic hormone makes you hold on to your fluids. So if you don't have enough of antidiuretic hormone, which makes you hold on to your fluid, what are you doing to your fluids? You're letting it all go. That's why everybody gets urine. Okay? Diabetes insipidus is a lack of ADH, which results in production of copious. That word copious means a whole lot. Copious amounts of glucose-free urine. So let's talk about this because it's something else that's very important to know. So diabetes insipidus, you're urinating all over the place, right? But that urine is dilute. It's dilute. All of those electrolytes, the osmolality is decreased because even though you have all this urine that you're letting go, you're holding on to the sodium, you're holding on to everything that would make that urine heavy. So even though the urine output, look at me guys, even though the urine output is doing this, that urine output is up, right? The urine osmolality is down. Why is the urine osmolality down? Those solutes such as the sodium stays in the bloodstream. So the serum osmolality is up. Make sure you guys be very closely. It's little things like that that NCLEX will get you with. Are we talking about the urine or are we talking about the serum? So you have to understand what's happening here. Don't try to memorize. Diabetes insipidus. ADH is up or down?
Down.
Down, right? ADH is down. And that's why the urine output is up or down? Up. Okay, good. You're with me so far. So urine output is up. Patients urinating all over the place. The urine osmolality, is that going to be up or down? Down, because those solutes have stayed where? In the blood. So the serum osmolality will be what? Very good, up. You guys got it, perfect. Let's keep going. Dwarfism. That's having small stature, and that's from a lack of growth hormone. So when you have too much of the growth hormone, it's acromegaly, and when you don't have enough, it's dwarfism. Next, how do I pronounce that? Gigantism?
Yeah.
Gigantism, thank you. That's a response to excess levels of growth hormone before the epiphyseal plates close. You see that phrase, epiphyseal plate? That is where the growth in the bone takes place. Okay, that's important for you guys to know. So it's response to excess levels of growth hormone before the epiphyseal plate closes. Height of 7 to 8 feet are not uncommon. Lastly, hypopituitarism. This is lack of adequate function of the pituitary gland. It's reflected in many of the endocrine disorders, which we are going to be covering. Drug list. So drug cards I'm going to need from you guys. The first one, the first class is going to be the growth hormone agonists, which includes your somatotropin and your somatropin and your somatropin rDNA origin. That's your first card you're going to give me. Next, the second one are going to be drugs affecting the posterior pituitary hormones, which includes Desmopressin and these other two I'm not even going to try to pronounce. Make sure you know the Desmopressin. That's your second drug card you're going to give me. Well, well, well. Look what we have here. Look at this figure again. Remember, I told you guys, whenever an author presents the same information to you in different ways, that means you're going to see it on the test somewhere. That means it's very important for you guys to know. They just gave it to us in chapter, whatever that last chapter was, and now we're seeing it again. Okay, so make sure you know which hormones belong in which part of the pituitary. Okay? And make sure you know, obviously, guys, make sure you know your hormones and what they're responsible for as well. Page 579. Hypothalamic and pituitary agents. Let's start with children. Look at what it says. Children who receive any of the hypothalamic or pituitary agents need to be monitored closely for adverse effects associated with changes in overall endocrine function, especially growth and development and metabolism. Why? Because they're still growing, and especially children, their rate of growth is much higher than that of the adult. Periodic radiographs, so that they're talking about x-rays, periodic radiograph of the long bones, as well as monitoring of blood sugar levels and electrolytes should be a standard part of the treatment plan. Children who are using Desmopressin, by the way, don't forget that's one of the cards you're going to owe me. Desmopressin for diabetes insipidus need to have the administration technique monitored and should have an adult responsible for the overall treatment protocol. Remember, and we're going to talk about this, but when it comes to diabetes insipidus, remember, patients urinating all over the place, but solutes such as glucose stays where? In the blood. So this patient might have to be treated with what? With what? Insulin. Possibly. All right, adults. Adults also need frequent monitoring of electrolytes and sugar levels when receiving any of these agents. Adults receiving regular injections of the drug should learn the proper storage, administration techniques, rotation of injection sites. And then older adults. Guys, you know this. When it comes to the geriatric patients, kidneys not working the way it used to, liver's not working the way it used to, so they're at very high risk of toxic effects, right? So they should be evaluated periodically during treatment for hydration and nutrition, as well as electrolyte imbalance. Okay, so we stopped here on page 579. Next week, I'm going to complete the rest of chapter 35. I'm just not doing it now because I forgot to read it. So we're
I was wondering on the damn.
I had to watch your mouth. I had a busy week. I don't know. I guess I forgot about it. Maybe I thought I read the entire chapter and I didn't. Obviously, it's not highlighted, so I didn't read it. So remind me next week, guys, when we start, for me to go back to the rest of that chapter covered for you. Let's jump to chapter 36. Adrenal cortical agents. So we're going to be talking about those hormones produced by the adrenal glands. Remember, those adrenal glands sit right on top of your kidney. If you guys were to go like this and put your hands behind your back right here, where you see my palms, those are where your kidneys sit more or less, okay? And so the adrenal glands sit right on top of the kidneys. Key terms. Adrenal cortex. This is the outer layer of the adrenal gland, because the adrenal gland has two layers. It has the medulla, which is the middle, and that's easy to remember, medulla, middle, and then cortex is the outer. So the adrenal cortex, that's the outer layer of the adrenal gland. And look at this, it produces glucocorticoids and mineralocorticoids. When you think of glucocorticoids, you need to think of what? Sugar, very good. When you think of mineralocorticoids, you need to think of what? Salt. What did you say? Sodium. Sodium, yes, absolutely. Okay? Now, adrenal medulla, that's the middle. That's the inner layer of the adrenal gland. It releases norepinephrine and epinephrine. Those are our fight or flight hormones. I told you guys that story about Puerto Rico, right? No? Very quickly. Years ago, Matthew was just a baby then. We were vacationing in Puerto Rico, and I just bought a baby bag like outside of the Coach store, and I come out, and all I see is a white flowy skirt run past me. I'm okay, whatever. And then I realized I forgot my wallet, and I go back inside to the store, and the cashier said someone just picked it up, and I knew it had to be the lady in the white skirt. So I just throw Matthew at my husband, and I run after the lady. And Puerto Rico is very hilly, guys. So I run up the hill, she runs up the hill. She turns the corner, I turn the corner. She runs down the hill, I run down the hill. Let me tell you guys something. If someone could have brought me oxygen, I would have been so grateful. I did not catch her, but it taught me a lesson. Number one, if I was skinnier, I would have caught her. And after that vacation, I lost 40 pounds in 1 month because I said, if that ever happens to me again, I'm going to catch them. That's number one. And number two, God saved me because I would have been in jail somewhere if I caught her. But I had that energy, that sprint of energy because of epinephrine, norepinephrine. That's the fight or flight response. Am I going to fight whatever it is that's happening, or am I going to flight, run away? Either way, you need energy for that. Okay, so when you think of the adrenal medulla, you need to think of that fight or flight response. So if you get sick or there's some kind of stress to your body, you come home and you find your husband in bed with a secretary, are you going to beat them both up or just run away? Either way, you need the energy to do that. Okay, that's your epinephrine, norepinephrine. You'll never forget it. Corticosteroids. Steroid hormones produced by what? The adrenal cortex. Includes androgens. Those are your sex hormones. Glucocorticoids and mineralocorticoids. So think salt, sex, and sugar. Okay? Sex hormones. Your testosterone, your estrogen, right? Glucocorticoids, those are your sugar. And mineralocorticoids, those are your salt, sex, and sugar. Glucocorticoids, these are steroid hormones released from the adrenal cortex. They increase blood glucose levels, fat deposits, and protein breakdown for energy. Now, something I want to bring to your attention, they also increase protein breakdown for you to get energy, right? Well, guess what? What do you need for healing? Vitamin C and what? Protein. So already, what do you think if a patient has too much of this can kind of put them at risk for? They would be at risk for what? Infection. It makes sense, right? Not to mention the anti-inflammatory response, but we'll get into that. And last, mineralocorticoids. These are steroid hormones released by, again, adrenal cortex, and they cause sodium and water and potassium excretion. Remember, fluids follow sodium, so where sodium goes, fluid follows, right? Drug cards. Drug card number 3 are going to be my glucocorticoids. The beclomethasone, the betamethasone, budesonide, cortisone, dexamethasone, all of these. You need? On the side? Oh, for glucocorticoids, I wrote think sugar, and for mineralocorticoids, I wrote think sodium. So drug card number 3 are my glucocorticoids. Drug card number 4 are my mineralocorticoids. Includes your cortisone, hydrocortisone, that whole list. Adrenocortical agents are widely used, look at this, guys, to suppress the immune system and help people feel better. These drugs do not, however, cure any inflammatory disorders. They don't cure, they just treat. So let's start with adrenal excess. getting too much of those hormones that the adrenal glands produce. What can happen? And on the side, guys, I wrote too much salt, sex, and sugar. Excessive adrenal cortical excretion results in a disorder called Cushing's disease or Cushing syndrome. This could be the result of, and they give you the list, you guys can read that on your own. The person with this disorder often presents with, this is important for you guys to know, moon face. Because one of the things with these hormones, and the word I'm looking for, it changes the fat distribution, okay? And it causes weight gain. So the patient will, often they'll have moon face, that big round face, that big puffy face. Central obesity, where you'll see their abdomen, their trunk is large, and then the extremities will be skinny, but that abdomen is large, okay? That's your trunkal obesity. Hypertension. Think about it. Increased salt, sex, and sugar, right? Your salt is high. What else is going to be high? Water, fluids, right? What is blood pressure? All blood pressure is how much fluid is being pressed against that vascular space. So obviously, the more fluid you have, the more pressure against the vascular space, the higher that your blood pressure is going to be. Increased protein breakdown. And we know protein's important. Number one, it helps to build muscle, but protein's good for healing. And osteoporosis. We know that about steroids. Steroids can cause the bones to be porous. That's why we got to watch out for fractures in patient who's on steroids long term. Females develop hirsutism. Remember, increased salt, sex, ding, 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 sugar, sex, those secondary sex characteristics. So the women can grow mustaches and beards, and the men can get man boobs, known as what? What's the correct name for that, guys? It starts with a G. Gynecomastia. Very good. That wasn't very professional calling them man boobs, but you know what I mean, right? All right. A medication to treat Cushing's in patients for whom pituitary surgery is not an option. Let's stop right there. Look what they just said. When pituitary surgery is not an option. So those who can't get surgery, what are the other options? So let's take a look at this box. Alternative therapy. This medication, Signifor, is used for the treatment of adults with Cushing's disease. Look at this, for whom pituitary surgery is not an option. So unfortunately, you know, guys, we don't like going to the most invasive choice first. But when it comes to a disorder like this, if surgery is an option, that's what we're going to do. We're just going to remove it, right? But if that's not an option, that medication, Signifor, is an alternative. This drug is a somatostatin analog. A somatostatin is also known as a growth hormone inhibitor. It stops that growth hormone. This drug binds to somatostatin receptors. The drug is given sub-Q, so it's given in the fat twice a day with dosing adjusted based on patient response. It's absorbed slowly, metabolized in the liver and kidneys, and it's excreted mainly, look at this, guys, through the feces. So I want you to think about it. This patient that has Cushing's, and for whatever reason, they can't get surgery, right? So we got to give them this medication, this Signifor, right? Would this be a good medication to give the patient if they have bowel obstruction? No, because look at how it's excreted through the feces. Aren't we going to be very careful if this patient has a liver or kidney issues, since the liver metabolizes this drug and the kidney helps to excrete at least a little bit of this drug, right? So we got to be careful. There is a risk of hypocortisolism, hyperglycemia, and diabetes, bradycardia, and prolonged QT intervals with this medication. Liver function impairment and gallstones have also been reported. All right, let's talk about the opposite end of the spectrum. Adrenal insufficiency. That's when the patient doesn't have enough salt. They don't have enough sex. They don't have enough sugar. What can happen to them? Some patients experience a shortage of adrenal cortical hormones and develop signs of adrenal insufficiency. Just like when we're talking about adrenal excess, you should think Cushing's. When they talk about adrenal insufficiency, you need to think of Addison's disease, where you need to add salt, add sex, add sugar, okay? This can occur when a patient does not produce enough adrenal corticotropic hormone, when the adrenal glands are not able to respond to the adrenal corticotropic hormones, when the adrenal gland is damaged, it cannot produce enough hormones, such as in what? Are you guys awake? Addison's disease, yes, or secondary to surgical removal of the glands. That's important. So if the patient had some kind of condition where that adrenal gland was removed, and the adrenal gland, we know, is what produces that salt, sex, and sugar, that's going to automatically throw that patient into Addison's disease, okay? A more common cause of adrenal insufficiency is prolonged use of corticosteroid hormone. And here's why. So after the patient's been taking these steroids for a while, the adrenal gland's like, why am I working so hard? I'm getting an exogenous source. Let me stop. And so the patient stops, and then their body stops making that hormone that they used to make endogenously, and then the patient stops taking that exogenous source. That can throw them obviously into adrenal insufficiency. And that's why patients can never stop that medication abruptly. They have to be weaned off. Why? Because if they've been taking that medication for a long time, they have to slowly get that dose tapered off so the adrenal gland can wake up and say, whoa, I'm not getting enough of that exogenous source as I used to. Let me start releasing more of this hormone. If that patient stops it abruptly, yeah, they're going to have adrenal insufficiency because there was not enough time for the body to even recognize that the patient stopped taking this from an outside source and the body didn't produce it. Yes, ma'am.
Does that only happen with systemic corticosteroids, or does it also happen with
Really systemic. I have never seen it happen with topical. I think it's possible, but just to be honest, I haven't seen it. Really systemic. All right. Table 36.1. Let's look at the differences between your Addisons and your Cushing's. You guys have to know this. And over here on the side, I wrote all of these on NCLEX. You got to know the difference. So in Addisons, where you need to add salt, add sex, add sugar, what are those signs and symptoms? Confusion from that decreased what? Sodium. Remember everything you guys learned in foundations of nursing. Is that where you guys learned fluid electrolytes, or you learned that in case management? Patho, excuse me. So you guys bring that back into recall what you learned in patho. Hypotension because of that decreased salt. Arrhythmias, cardiovascular collapse, hyperpigmentation. And that hyperpigmentation, guys, that's what's known as the eternal tan. If you guys remember, what's that president everyone liked? He had the affair with Marilyn Monroe, supposedly. Yes, thank you, JFK. JFK had Addison's. He had that eternal tan. Did he always look tan? Yeah, that's a hyperpigmentation. What about metabolic rate? Patients going to have hyponatremia. That's why we need to add salt because they don't have it. Hypoglycemia. That's why we need to add sugar because they don't have it. Weakness, dehydration, poor response to stress. Think about it. The adrenal gland, not only are they responsible for that salt, sex, and sugar, they're responsible for that epinephrine, norepinephrine, your fight or flight, right? When you're exposed to stress, they need to be released to help you either fight or flight. So if this patient has Addisons, they don't have enough of that. So yes, they're going to have a poor response to stress. So these type of patients, you need to tell them to stay away from stressful environment. If your husband or your wife is a jerk and they're stressing you out, leave them. Your life's more important. No, I'm not saying anyone want to leave their spouse, but you know what I mean. All right. Cushing's disease, that's hyperadrenal function. They're going to have emotional disturbances. And if I had moon face, buffalo hump, purple striae, what's that called in the middle? The central obesity. I'd have emotional disturbances too. Hypertension, purple abdominal striae, hirsutism, hyperglycemia, hypokalemia, hypernatremia, osteoporosis, amenorrhea, moon face, buffalo hump, obesity, immune and inflammatory suppression. So this kind of patient, we got to teach them, stay away from crowds, stay away from sick people. Their body cannot handle it. Make sure you know this table.
Under skin, hair, nails, does that say external?
I'm sorry?
Under skin, hair, and nails, you have a little note right there.
In here. Oh, I wrote forever tan for the hyperpigmentation. You're welcome. All right, now let's talk about adrenal crisis. We talked about adrenal excess, adrenal insufficiency. Now we're going to talk about adrenal crisis. Patients who have an adrenal insufficiency may do quite well. So the patient's not making enough salt, sex, sugar, but they're doing okay. They may do quite well, look at this, until they experience a period of extreme stress, such as a car accident, a surgical procedure, or a massive infection, because aren't those stresses on the body? Remember, when you have adrenal insufficiency, you're not having that salt, sex, sugar, the norepinephrine, epinephrine, those fight or flight responses. You don't have that to help you fight off whatever that stress is to your body. Because they are not able to supplement the energy consuming effects of the sympathetic reaction, because it takes energy to do one or the other, fight or flight. You need energy for both. They enter an adrenal crisis, which can include physiological exhaustion. Let's stop right there for a moment. When I talk to you guys about physiological integrity, things that physically keep your patient alive, which are always going to be a priority, right? Does it rest fall in there? Isn't rest right there with fluid electrolytes, glucose, ABC, hemodynamic status, vital signs, all that good stuff? Absolutely. So that physiological exhaustion can be enough to kill the patient or severely damage them. Hypotension, fluid shift, shock, and even death. So adrenal crisis is a medical emergency, guys. Patients in adrenal crisis are treated with massive infusion of replacement steroids. Whatever they're missing, we're going to give it to them, big time. Massive infusion of replacement steroids, constant monitoring. So they're definitely, guys, they're going to be on what's that? Thank you. They're going to be on tele because they need that constant monitoring, and life support measures. Because remember, this is a medical emergency. Key points. Corticosteroids help the body conserve energy for fight or flight response, and they maintain fluid balance. Prolonged use of corticosteroids suppresses the normal hypothalamic pituitary axis, and it leads to adrenal atrophy from lack of stimulation. Adrenocortical agents. There are 3 types of corticosteroids. Your androgens, remember those androgens, those are your sex hormones. Glucocorticoids, those are your sugars, and mineralocorticoids, those are your salts. Not all adrenocortical agents are classified as only glucocorticoids or mineralocorticoids. Hydrocortisone, cortisone, and prednisone have glucocorticoid and some mineralocorticoid activity, and they affect potassium, sodium, and water levels in the body when they're present in very high levels. Take a look at this table 36.2. Make sure that you know which of these drugs fall under short-acting corticosteroids, which is your cortisone and your hydrocortisone. Make sure you know which drugs fall under intermediate-acting corticosteroids, which is your prednisone, prednisolone, triamcinolone, and methylprednisone. And make sure you know what drugs fall under your long-acting corticosteroids, which is your dexamethasone and betamethasone. Yes, ma'am.
So we don't need to know the dosage.
No, you don't need to know the dose or duration. Just know if it's short, intermediate, or long-acting. And that's all I wrote on top. Know the difference. All right, let's take a look at box 36.3 corticosteroids, children, adults, and older adults. Let's start with children. Children need to be monitored closely for any effects on growth and development. That's the second time we're seeing this, isn't it? Topical use of corticosteroids should be limited in children. Apply sparingly and do not use in the presence of open lesions. Remember, if there's an open lesion, that medication is going to be absorbed much more rapidly than intended. Do not occlude treated areas with dressings or diapers. Diapers are considered an occlusion. Children receiving a long-term therapy should be protected from exposure to infection. Special precautions should be instituted to avoid injury. Let's move on to the adults. Adults should be reminded of the importance of taking these drugs in the morning to approximate the diurnal effect. That's basically what they're talking about, is that sleep-wake cycle. We want to mimic the natural endogenous hormones that are produced in the body. You're going to teach the patient if they have to be on that medication, it has to be tapered off. They should not stop it abruptly. That could throw them into adrenal crisis or adrenal insufficiency. Several over-the-counter topical preparations contain corticosteroids, and adults should be cautioned to avoid combining those medications or preparations with prescription topical steroids. Avoid applying them to open lesions or excoriated areas. Avoid exposure from infection, because remember, guys, these steroids, three things, if you remember anything about steroids, well, there's lots you gotta remember, but important things to remember about steroids, they hide this, they maskify the symptoms of infection, because remember, they have anti-inflammatory properties, right? So you gotta be thinking of infection. The second thing you need to be thinking of is fractures, because they make the bone porous. And the third thing, I haven't seen the book mention it yet, but this is very important, and NCLEX expects you to know it. So I'm going to say to you, ulcers. They're very hard on the stomach and can cause ulcer. And so you got to watch out for that.
That's for corticosteroid.
I'm sorry?
That's for corticosteroid.
Systemic. Crowded areas, avoid infection, avoid crowded areas, people with colds or the flu, avoid activities associated with injury, because remember, their bones can be porous. Avoid anything that can cause them stress. If an injury or infection should occur, the patient should be encouraged to seek medical care. Monitor the glucose levels, because remember, they're very sugary. It can increase the patient's glucose. These drugs should not be used during pregnancy. Nursing mothers should find another way to feed the baby, because it does transfer through the breast milk. Now for older adults, the dose should be reduced and the patient monitored closely. Older adults are more likely to have medical conditions that could be imbalanced by changes in fluid and electrolytes, metabolism changes, and other drug effects. Why? Because remember with that geriatric patient, they're already at risk for dehydration. Remember the geriatric population, you have to constantly remind them to take sips of water. Remember, they lose their sense of thirst. So they're already at risk for dehydration. They're already at risk for fluid electrolyte imbalance. They're already at risk for toxicity. Glucocorticoids. Glucocorticoids are so named because they stimulate an increase in glucose levels for energy. They also increase the rate of protein breakdown and decrease the rate of protein formation from amino acids, and that's another way that preserves energy. Glucocorticoids also cause lipogenesis, lipo fat genesis, production of or making, building, right? Glucocorticoids also cause lipogenesis or the formation and storage of fat in the body. So now that makes sense, that patient with adrenal excess, why they would have that moon face, right? That truncal obesity. The stored fat will then be available to be broken down for energy when needed. And here, guys, they give you the list of glucocorticoids. Make sure you know those medications, have them on the drug card for me. Glucocorticoids are indicated for the short-term treatment of many inflammatory disorders to relieve discomfort and to give the body a chance to heal from the effects of inflammation. They also impair the ability of phagocytes to leave the bloodstream and move to injured tissues, and they inhibit or stop the ability of lymphocytes to act within the immune system, including blocking the production of antibodies. So, and that's a big reason why it puts that patient at risk for infection. The type of patient we need to tell them to stay away from sick people, stay away from crowds, stay away from situations that could cause stress to the body. Pharmacokinetics. Page 600. Pharmacokinetics. The glucocorticoids are known to cross the placenta and enter breast milk. They should be used during pregnancy and lactation only if it benefits the mother, if the benefits to the mother clearly outweighs the potential risk to the fetus and neonate. Beclomethasone and fluocinolone are available in the form of respiratory inhalant. Betamethasone is a long-acting steroid. Budesonide is available for intranasal use. Cortisone is used orally and parentally. Dexamethasone and triamcinolone are available in multiple forms. Prednisone is an intermediate-acting corticosteroid with effects lasting only a day or so. It's used for intralesional and intra-articular injection. It's also available in oral and topical forms. Prednisone is available only as an oral agent. Contraindications and cautions. Obviously, if there's any allergy to the glucocorticoids, that's a contraindication. If the patient has an acute infection, that obviously is a contraindication. We know that these glucocorticoids can cause that patient to be at risk for infection, right? Why would we give this to them if they already have an active infection? Lactation. Caution should be used in patients with diabetes. Think about it. We know glucocorticoids increase the patient's blood sugar, so we're going to be very careful if the patient's blood sugar is already through the roof. If the patient has active peptic ulcers, why? Because we know glucocorticoids can cause ulcers. Where is the Kleenex I had on my desk? Did I see Kleenex? No, that's my Amazon package on top. Oh, that's my Dunkin' Donuts. Look at that table back there. Do you see Kleenex box? No?
I have a tissue. or
Oh, please.
uh,
Thank you. Thank you. All right. So we know that glucocorticoids can cause ulcers, so that's gonna be a contraindication if the patient already has a peptic ulcer, or the patient has other endocrine disorders, or if they're pregnant. Adverse effects. Methylprednisone is associated with increased toxicity in African Americans. That's important for you to know. Methylprednisone is associated with increased toxicity in African Americans. Box 36.4, cultural considerations. African Americans can develop increased toxicity to the corticosteroid methylprednisone, especially when it's used for immunosuppression after renal transplantation. So the author just told us this, that it's not good for African Americans, and they decided to put it in a box. You think you're going to see that on a test? Absolutely. Mine. If an African American patient is being treated with methylprednisone, extreme care should be taken to adjust doses appropriately and to treat adverse effects as they arise. Are you raising your hand or just stretching? Okay. No. So let's look at box 36.5, adverse effects of corticosteroid use associated with various routes of administration. So we've seen all of this already. These are just reminders, guys. They can cause peptic ulcers, esophageal ulcers, weight gain, fluid retention, thromboembolism. Now, thromboembolism, I don't think we saw in the book before, but that is a very important adverse effect to know about. Fat embolism, sodium and fluid retention, increased blood sugar, osteoporosis, and puts the patient at risk for fractures. Frail skin. Their skin will be like paper thin, and they'll bruise very easily. Petechiae, purpura, striae, amenorrhea, diabetes, Cushing syndrome, immunosuppression, that puts them at risk for infection, impaired wound healing. Drug-drug interactions. Therapeutic and toxic effects increase if corticosteroids are given with, make sure you know this list, erythromycin, ketoconazole, or somebody pronounce that drug for me. Trilindomycin, thank you. So if corticosteroids are given with those drugs, the toxic effects increase. Now, the serum levels and effectiveness may decrease if corticosteroids are given with salicylates, barbiturates, phentoin, that's your dilantin, or rifampin. So you need to know which drugs, when combined with corticosteroids, can cause toxicity, and which drugs, when combined with corticosteroids, can decrease the effectiveness, okay? Nursing considerations for patients getting glucocorticoids. You're going to assess them for allergy, acute infections, pregnancy, lactation, peptic ulcer disease, endocrine disturbances, renal dysfunction. You're going to assess their weight. We need a baseline because remember, one of the things that this does is cause you to gain weight, right? So we're going to assess their weight, their temperature, their orientation, affect, their grip strength, we're going to do an eye exam, blood pressure, pulse. We're going to do a complete checkup on that patient because we need a baseline for them. We're going to do a glucose tolerance test, renal functions, serum electrolytes, fluid electrolytes. Nursing diagnoses for patients on glucocorticoids. Altered cardiac output. Because remember, because they're holding on to all that fluid. That patient can have hypertension, excess fluid volume, disturbed sensory perception. That's their vision can be affected, so they can get glaucoma. So that's why one of the reasons that one of the assessments that we do is an eye exam. We need that baseline. Risk for infection, ineffective coping. Remember, this patient can't stand any type of stress. Deficient knowledge and imbalanced nutrition. These are very big nursing diagnoses for the patient on glucocorticoids. Implementation rationale. You're going to administer the drug daily at 8 to 9 a.m. Why? We want to mimic the endogenous release of that same steroid of the body. So it's not something you're going to give at nighttime. You're going to give in the morning. Space multiple doses evenly throughout the day to try to achieve homeostasis. Use minimal dose for minimal amount of time. So the minimal dose that will be effective for that patient, that's what we want to use. Taper. Taper doses when discontinuing from high doses or from long-term therapy. That patient should not stop abruptly. That can throw them into adrenal crisis, or at the least, adrenal insufficiency. Look at all these NCLEX. Arrange for increased dose when the patient's under stress. NCLEX loves asking about this one because they expect you to know that even though the patient may have, let's say their dosage was 30 milligrams, if something's happening, they're getting surgery, they just had a car accident, their husband just left them, something that caused a huge stress psychologically or physically, they may need more to compensate. Use alternate day maintenance therapy with short-acting drugs whenever possible. Do not give live virus vaccines when the patient's immunosuppressed. Guess what? If you're taking this long-term, they're going to be immunosuppressed. So it's not like we're going to give them, any live vaccines. Protect the patient from unnecessary exposure to infection and invasive procedures. Because anything that's invasive, that's an opportunity to introduce bacteria and pathogens into the patient's body, and that patient cannot afford to get sick. So we're going to teach them to stay away from people who are sick. Stay away from large crowds. If you're on these medication, you're not the one who needs to go to a Chris Brown concert. Watch it from TV or online. Assess the patient carefully for any potential drug-drug interactions and provide thorough patient teaching. Remember, guys, one of the best ways to alleviate patients' anxiety with this type of patient, they can't be anxious, they can't be fearful, because remember, that's psychological stress, right? One of the best ways to relieve that is just by teaching. The more that you teach them and the more that they understand and then they know, that decreases their fear and the psychological stress on them. All right, over here is a case study about a patient. You guys can read that on your own, but the point is they got prescribed prednisone. So what are you going to teach the patient? All of these are reminders. You're going to teach them that medication can slow down the healing process. You're going to teach them to never stop that medication abruptly. You're going to teach them that prednisone can increase their appetite. They're going to gain weight. They may have restlessness or trouble sleeping for some people. They can have, that's going to increase their risk for infection. You're going to teach them to report any of these to the doctor. Now, this looks like a beautiful select all that applies to me. What are they going to report? Sudden weight gain. What did I tell you about that word, sudden and severe? You see that? That's important. It needs to be reported, right? Sudden weight gain, fever, sore throat, black tarry stools. Maybe that patient had an ulcer, we didn't know about it, started bleeding. Swelling of the hands or feet, any signs of infection or easy bruising. If you're taking this drug for a prolonged amount of time, limit your intake of salt or salted products and add protein to your diet. Why? Because you're already gonna hold on to your sodium, which makes you hold on to fluid, right? And then your body's already going to be breaking down protein, and we need protein for healing. Avoid any over-the-counter medications. Do not take them without talking to your healthcare provider first. Any doctor that you're seeing, any healthcare provider that you're seeing, let them know that you're on this medication. Teach them to wear a medical alert bracelet. NCLEX has asked about this as well. You got to teach that to your patient, because if something happens that they pass out or they're unable to communicate, whoever's trying to help them needs to know that they're on the steroid, because what if the reason that patient passed out, they've gone through adrenal crisis or something else? Have regular follow-ups with your healthcare provider. Don't miss any visits. Keep this drug out of the reach of children. Do not give your medication to anyone else. Key points. The glucocorticoids increase glucose production. They stimulate fat deposition and protein breakdown, and they stop protein formation. Patients receiving glucocorticoids need to be protected from exposure to infection. They need to have their blood sugar monitored regularly and dietary changes made as needed. Teach them that they will not heal well because of the blocking of the protein formation. Protein is needed for healing. And in parentheses, I wrote that protein and vitamin C help with healing. Keep that in mind. You guys need a bathroom break, or you good? Yes. All right, take 10 minutes.
Can I take a book really quick, just to make sure?
Sure.
Yeah.
All right. We're on page 604, mineralocorticoids. When you think of the mineralocorticoids, you think of what?
Sugar.
Salt. Who said sugar?
And the glucose.
Salt, very good. The classic, and you see that term classic, whenever you see classic, ding, ding, ding. The classic mineralocorticoid is aldosterone. You need to know this. Aldosterone holds sodium, and with it, water, because water follows sodium. It causes excretion of potassium by acting on the renal tubule. You know, potassium and sodium like going the opposite way. So it's holding on to sodium. You know, potassium is going. Mineralocorticoids that are available include cortisone, fludrocortisone, and hydrocortisone. Therapeutic actions and indications. Mineralocorticoids increase sodium reabsorption in the renal tubules, leading to sodium and water retention and potassium excretion. Be very careful with that word. You see that word reabsorbed? That A makes such a big difference. Read very carefully, because I can't tell you how many test questions I've seen where it says resorb, and when it says resorb, it's letting go of, or reabsorb, it's holding on to. The A makes a big difference, okay? So it says sodium reabsorption and potassium excretion. Fludrocortisone is a powerful mineralocorticoid and is preferred for replacement therapy over cortisone and hydrocortisone. It's used in combination with a glucocorticoid. Pharmacokinetics. When it comes to the mineralocorticoids, you want to avoid them during pregnancy and lactation. Contraindications and cautions. Any known allergy, that's a contraindication. Severe hypertension, and that makes sense because the patient's already holding on to sodium and fluid. So why would we give this to a patient that has severe hypertension? Are we trying to give them a stroke, right? Heart failure, patients already holding on to sodium and fluid. Why would we give this to a patient who has heart failure, where they already have too much fluid and now the heart's been weakened? cardiac disease, lactation, pregnancy, any known infection. If the patient has a known infection, and we know that the mineralocorticoid is going to put them at risk for infection, that makes no sense. Adverse effects of the mineralocorticoids. Oh, before I get to adverse effects, here's another contraindication. If the patient has high sodium intake. Adverse effects of mineralocorticoids. It's related to increased fluid volume seen with sodium and water retention, such as headache, edema, hypertension, heart failure, arrhythmias, weakness, and possible hypokalemia. Because remember, with the mineralocorticoids, yes, it holds on to sodium, but it lets go of what? Potassium. And potassium has a very narrow therapeutic range, 3.55. So if this patient is already hypokalemic, and you were to give this to the patient, you know that's going to bring them way below that 3.5, and you're going to cause cardiac arrhythmias and all types of other issues. Drug-drug interactions, decreased effectiveness if taken with salicylates, barbiturates, hydrantoins, rifampin, and anticholinesterases. So the mineralocorticoids will not be as effective if they're taken with salicylates, barbiturates, hydrantoins, rifampin, and anticholinesterases. Nursing considerations for patients receiving mineralocorticoids. We're going to assess them for any allergy, heart failure, hypertension, current infections, high sodium intake, lactation, pregnancy. Why? Remember, all of those are contraindications. We need a baseline. We're going to check their blood pressure, pulse, check for adventitious breath sounds. Are adventitious breath sounds good or bad? Bad. We want to make sure when we listen to the lungs, we don't hear any crackles. Because remember, this patient's already prone, like because of the sodium, them holding on to sodium, they could hold on to fluid. We don't want them holding on to too much fluid. That fluid got spilled over somewhere and not spilled over to the lungs. Now we listen to the lungs and we hear crackles. So if we were about to give this medication, we listened to the lungs and we heard crackles, would we hold the medication or still give it? Hold it. Hold it and call the healthcare provider. So we're going to watch out for adventitious breath sounds. We're going to take their weight. We're going to check their temperature. We're going to look at skin turgor, reflexes, grip, serum electrolyte levels. Nursing diagnoses for patients taking mineralocorticoids. Imbalanced nutrition, more than body requirements. Fluid volume excess. Impaired urinary elimination. They're holding on to that sodium. Deficient knowledge. Implementation rationale. Look at how many stars and NCLEX I have over here. Use only in conjunction with appropriate glucocorticoids to maintain control of electrolyte balance. Increase dose in times of stress to prevent adrenal insufficiency and to meet increased demand for corticosteroids under stress. So if that patient is going to be under duress, under stress due to surgery, they have a massive infection, whatever it is, they're going to need more of a dosage. Monitor for hypokalemia. Remember, potassium has a very narrow therapeutic range. And we know with the mineralocorticosteroids, we know that the sodium is going to be up and that potassium is going to be down. We need to make sure it doesn't get lower than 3.5, lower than 3.5, right? Signs and symptoms of hypokalemia, weakness. Make sure you guys review those symptoms. You're going to look at the serum electrolytes. Discontinue if the patient has signs of overdose, such as, it doesn't just say weight gain. What's in front of weight gain? Excessive. Because we expect them to gain weight, right? But not excessive weight gain. Here's what you need to be thinking. When you see excessive weight gain, the reason you need to be so concerned. If the patient has excessive weight gain and it's sudden, do you think that it's really fat? What's causing this weight gain? fluid. And last time I checked, when it came to priority patients, when it came to patients that were in trouble, when it came to patients that we're going to run to, that we're going to see first, patients that have a problem with physiological integrity. Isn't fluid and electrolytes part of physiological integrity? Absolutely. Okay. Where were we? Excessive weight gain, edema, hypertension, cardiomegaly, all of things that can kill the patient very quickly. You're going to provide a thorough patient teaching. Key points. The mineral corticosteroids, that's, remember the sodium, you're going to think of aldosterone, it stimulates retention, holding on to, retention of sodium and water, and excretion of potassium. They're used therapeutically in conjunction together with glucocorticoids to treat adrenal insufficiency. Patients receiving mineralocorticoids need to be evaluated for possible hypokalemia and its associated cardiac effects, and for fluid retention that could exacerbate heart failure and cause electrolyte abnormalities. Summary, important things to remember. The adrenal medulla releases norepinephrine and epinephrine into the bloodstream. Adrenal cortex produces 3 types of corticosteroids. Those are your androgens, your glucocorticoids, and your mineralocorticoids. The corticosteroids are released normally in a diurnal rhythm. Corticosteroids are also released as part of the sympathetic stress reaction to help the body conserve energy for fight or flight response. Corticosteroids need to be tapered slowly. If you do it abruptly, you're going to throw that patient in the crisis. It needs to be tapered slowly after prolonged use. Glucocorticoids increase glucose production, stimulate fat deposition and protein breakdown, and they stop protein formation. They block inflammation and immune response, and in conjunction with mineralocorticoids, they're used to treat adrenal insufficiency. They're given together. Mineralocorticoids stimulate retention of sodium and water and excretion of potassium. They're used therapeutically, again, together, in conjunction with glucocorticoids to treat adrenal insufficiency. Adverse effects of corticosteroids: immunosuppression, peptic ulcer formation, fluid retention, edema. Make sure you know those adverse effects. All right, next week, we have a little bit of time. You guys want to move on to the next chapter? Yeah, let's move on. Yeah, did. All right, thyroid and parathyroid agents. Important terms to know. Biophosphonates. These are drugs that are used to block the, look at this word, guys, resorption. Used to block the resorption and lower serum calcium levels in several conditions. And in parentheses, I wrote not reabsorption. Make sure you know the difference. Calcitonin. Calcitonin, this is hormone produced by the parafollicular cells of the thyroid, and it counteracts the effects of parathyroid hormone to maintain calcium levels. Remember, the parathyroid hormones are important to increase calcium where? In the bones or the blood? In the blood. You guys are killing me. In the serum, in the blood, right? So calcitonin does the opposite. Hypercalcemia, too much calcium where? In the blood. Emia, blood, right? That's excessive calcium levels in the blood. Hyperparathyroidism. That's excessive I can't pronounce that word to save my life, parathormone. And remember, parathormone, that's important for calcium in the blood. Hyperthyroidism. Do not confuse the thyroid with the parathyroid. Your thyroid's right here on your neck, right? Remember, your thyroid's important for metabolism, right? The parathyroids, which are these 4 glands that sit right behind your thyroid gland, that is important for calcium in the blood. Don't confuse the two. So when it comes to hyperthyroidism, if we're talking about the thyroid, we're talking about increased metabolism. Hyperthyroidism, excessive levels of thyroid hormone. Hypocalcemia is decreased levels of calcium in the blood. I know it's a lot to know. Hypoparathyroidism. That is a rare condition of absence, not having the parathormone. And remember that parathormone is important for calcium where? In the blood. Very good. And we often can see hypoparathyroidism after the patient has had a thyroidectomy, which is removal of the thyroid gland. And it makes sense because I just told you that those 4 little nodules, the parathyroid gland sits right behind the thyroid gland. So if the patient has a thyroidectomy, that thyroid removed, well, guess what else they got removed? The parathyroid gland. So it makes sense. Hypothyroidism, that's a lack of sufficient thyroid hormone to maintain metabolism, because when you're thinking about the thyroid, you're thinking about metabolism, and when you're thinking about the parathyroid, you're thinking about calcium in the blood. Okay? Now, let me state something else, because you have to keep that in mind. Because I did just say when you think about the thyroid, you're thinking about metabolism, but remember also with thyroid is calcitonin. Remember, we just saw that in the definition. All right. And remember that actually lowers that calcium level. Where are we? Iodine. Iodine is a very important dietary element, and it's used by the thyroid gland. That's important to know. The thyroid gland to produce thyroid hormone, specifically your T3, T4. That T stands for thyroid. Okay. Levothyroxine. That is a synthetic as in man-made. It's not naturally occurring. It's a synthetic salt of thyroxine, your T4, a thyroid hormone. The most frequently used replacement hormone for treating thyroid disease. So the patient has hypothyroidism. The most common medication you see that they're going to get is going to be your levothyroxine, that replacement of the thyroid hormone that they no longer can make naturally. Metabolism, that's the rate in which the cells burn energy. When you think of metabolism, do you think of the thyroid or the parathyroid? Thyroid, very good. Myxedema. Myxedema, this is a severe lack of thyroid hormone in adults, which can cause hypothyroidism. Because remember, when you're thinking about the thyroid hormone, you're thinking about the thyroid gland. If the patient doesn't have enough of it, they're going to have hypothyroidism, right? And if that thyroid gland's working way too well, they're making way too much thyroid hormone, they're making way too much T3, T4, they have the opposite, hyperthyroidism. Paget disease. This is a genetically linked, that's important because, don't ask me why, I don't know, but NCLEX seems to, if they ask about Paget disease, there's 2 things that they usually like to ask in regard to this. Number 1, they want to see if you understand that's genetically linked. And number 2, they want to see if you understand that has to do with the bones, okay? It's a genetically linked disorder of overactive osteoclasts that are eventually replaced by enlarged and softened bone structures. So let's talk about osteoclast. Remember, osteoblast is to build up and osteoclast is to break down. So you have all this osteoclast breaking down of the bone, but when the bone rebuilds itself, look at what's happening here, guys. It's enlarged, but it's soft. So you have all these big old bulky bones that can't even do nothing because it's soft. easy fractures, right? So that type of patient that has this, we're gonna have to protect them from injury, don't we? You guys are gonna see this again when you get to peds. Parathyroid. It's responsible for maintaining calcium levels in conjunction with calcitonin. They balance each other out. I know. You guys said you wanted to keep going. Stop
I
sighing.
didn't say that. No, thank you, I did not. I said no.
Okay, no, let's get through these definitions and my drug cards.
All right.
Okay? All right. Postmenopausal osteoporosis. So let's talk about this before I even read the definition. So one of the big reasons, guys, that calcium remains in your bones and keeps your bones nice and strong, for women, it's estrogen, and for men, it's testosterone. So what happens is when the woman goes through menopause and that estrogen is severely decreased, basically the estrogen has the gun and it's pointing that gun at the bones and it's telling the calcium, you better stay in there, or I'm going to shoot you. So the calcium sees that they got the gun at us. So calcium's like, you know what, we're going to stay in the bone because we're not safe, right? But as soon as a woman goes through menopause, that estrogen goes down, there's no more guns. And calcium's like, woo, party time. Let's get out of here. And the calcium leaves the bones and goes to the bloodstream. So now this porous person has porous bones. They're at risk for fractures and at risk for stones, calcium stones, because all of the calcium that used to be in the bone, making the bone nice and strong, they're hanging out in the bloodstream. And God forbid if this person's not drinking lots of water, those calcium clump up, and before you know it, now the patient has another set of problems. Okay, so let's talk about postmenopausal osteoporosis. It's a condition in which dropping levels of estrogen allow calcium to be pulled out of the bone. And this doesn't only happen to women, because remember, for men, it's testosterone. Testosterone helps keep the calcium in the bone. Not the only, but a big difference is just not as dramatic. You know, for men, yeah, you know, the calcium levels may drop just, you know, slightly, but not to the point that it will affect them as much as it does women. Okay? Thyroxine. This is a thyroid hormone that's converted to, you guys see this, I'm not going to try to pronounce it. Say it louder for me. There you go, what he said, in the tissues, and it has a half-life of a week. All right, drug list. How many drugs do you guys have for me so far? 4? Okay, so this is going to be number 5. Number 5, thyroid agents. My thyroid hormones, this is the 5th drug card, levothyroxine, and the others. But the most important out of those are the levothyroxine. Make sure you know it. Number 6, the anti-thyroid agents, your thiamides. This drug, this is PTU. I'm not going to try to pronounce the whole name, but it's PTU. This drug, right here. Methimazole is very important as well. That's number 6?
Yeah.
All right. Number 7, iodine solution. This sodium iodine, this is the same thing, because sometimes NCLEX they'll present it like this, but sometimes they'll present it, they'll just say radioactive iodine. It's the same thing that they're talking about. So make sure you just understand both of them so you don't get tricked. All right, next page, parathyroid agents. That number 8?
Yeah.
Okay. 8, my anti-hypocalcemic agents, especially calcitriol. Number 9, my anti-hypercalcemic agents, especially biophosphonates, alendronate, those 2. Make sure you know them, like the back of your hand. And number 10, calcitonin. Make sure you know the calcitonin.